Uh, Good afternoon, everybody, and welcome to this 14th National Conference of the AOA. It's my pleasure to introduce Dr. Subramaniam Mahakali. He's a senior consultant at SRRV Hospital in Bangalore and has specialized training in CCT and FRCA from Nottingham, UK. He's a member of AOA India and has delivered lots of talks and has a lot of presentations and has got more than 15 peer-reviewed public articles and 3 textbooks. It's a pleasure to introduce Dr. Subramaniam.
Good afternoon to all of you. This is Dr. Subramaniam Mahakali saying hello from all the way from Garden City of Bangalore. My topic for the day is gastric ultrasound in obstetrics. My agenda is very simple. By the end of the day, I want every one of you to start using your ultrasound machine to perform gastric ultrasound. It's a very easy art, and I'm sure I want to convince you, all of you, by the end of the talk. The structure of the talk is going to be why this gastric ultrasound, how to perform gastric ultrasound, how to assess the contents in the stomach, what are the structured way of assessing the contents, how to use it in pregnant women, and is there any framework? If so, we'll see what is the framework to use gastric ultrasound as a point of care tool. Now, these are the 2 papers which I feel are seminal papers in this area. Way back in 2009, these 2 articles inspired me to read more about this. The more I read about it, the more I got impressed and started adopting it. And once I adopted it, I thought, why not do the research? And this led me to do some research, and we have published it in Indian Journal of Anesthesia. You will find that gastric ultrasound is even finds mention in the ISA guidelines on the perioperative fasting and feeding in adults. The statement says the gastric ultrasonography may be used as a bedside tool for assessing quality and quantity of gastric contents in the perioperative period. The quality and content of the contents of the gastric contents should be assessed in the right lateral decubitus position. Now, we anesthetists are very clever. We have found ways to systematically stratify the risk whenever there are risks. So, but one area where we have not used a structured way of assessment or objective way of assessment is the risk of pulmonary aspiration. In the past, we have relied on patients' words and the patient's background medical condition, and these were all passive measures to assess whether there is a risk factor for aspiration or not. In this current era, the modern era, we do have this ultrasound machine which can be used objectively to assess whether the stomach is full. Do we need to take any precautions? And if so, how to proceed? It is common for us. We will find patients coming with following co-morbidities. Not only in general population, it's there even in pregnant population as well. And these are some of the medications which does affect the gastric emptying. When so many conditions and so many medications can affect gastric emptying, it makes a point for us to start performing the gastric ultrasound. To perform this, all we need is an ultrasound machine. Any of the machines can be used, and we probably need to use more often the curvilinear probe. Fundamental to our gastric ultrasound is the understanding that the food we eat is partially digested in the stomach. The last part of the stomach to empty is the gastric antrum. And slowly we have found out that looking at the gastric antrum, we can see what is the total content in the stomach. Also, it's important to understand that this gastric antrum can be fairly easily identified both in fasting condition as well as when the stomach is full, because of the characteristic appearance of the gastric antral mucosa and serosa, the gastric antrum wall. So we will see how it appears when we use an ultrasound machine. Of all the parts of the stomach, the gastric antrum is one part which is easily amenable to gastric ultrasound. It is sandwiched between the liver in the front and probably pancreas and duodenum in the behind. And let us see how structured, in a structured way we can go through and identify it. What we have to basically do is put our ultrasound probe in a sagittal plane, sweep it from slightly left of the midline in the subgastric area, and slowly sweep it towards the right. All we have to do is you put it in the subcostal area, sweep it from slightly to the left of the median and to the right, till where the probe or the gastric antrum crosses the aorta. This is an important landmark. The structure is usually located around 3 to 4 centimeters deep. How it appears, we will see now. The scanning can be done in 2 positions, supine and right lateral. Of late, in those in whom the right lateral is not possible, we have been adopting semi-recumbent position or 45-degree head-up position. When we put the probe into this area, the images what we see are likely to be like this. Looks a lot of gray and white. But if we go through systematically, we can identify each and every one of the structures here, starting from skin, subcutaneous tissue, the muscle, the muscular plane with rectus sheath, the liver, and you can see the pulsation of the aorta and sometimes the superior mesenteric artery. You can also see the bubbles with which is forming the air shadowing there, and the duodenum and pancreas. Sandwiched between these two, which almost in an empty stomach appears as target-like appearance, is the gastric antrum. Now, if you look at the same picture, you can easily identify the stomach, isn't it? Now, how to go about once we've identified the gastric antrum? What kind of assessment can we do? There are 3 kinds of assessment one can do. That is qualitative, semi-quantitative, and quantitative. In qualitative assessment, what you do is you put the probe, identify the gastric antrum, freeze the image, and closely have a look at the what is inside the wall of the stomach or inside the stomach. So when the stomach is the gastric antrum, the wall has a characteristic appearance. It's hypoechoic in between the 2 layers of white, and as you can see here. And when the stomach is empty, so the mucosa can be opposing to each other, and it characteristically gives us a target-shaped appearance. When it's filled with water, like what you're seeing here, the antrum is dilated with an hypoechoic center in the middle. When it is filled with semi-solids or solids, you can see there is mixed echogenicity, and sometimes the solids stop the ultrasound waves. You can see the air shadowing as well. Now, so far what we have done is we have put the probe, identify the stomach, identify the gastric antrum, and carefully look at the contents. This is the qualitative assessment. If it is empty, you can grade it as empty. The solids, the liquids, and semi-solids have a characteristic appearance. So we can say, yes, this is what is the qualitative assessment showed to us. The implication, we will see what it is. The next point is how to do semi-quantitative assessment. So to do this, you can do the scanning. You have to do scanning in the right lateral position and in supine position. Start with supine first. If there are any solids or thick fluids in the stomach, take it as a high risk for aspiration. If it is empty in both the positions, you can grade it as grade 0. But if you find there is clear fluids there, do carefully the scanning in both the supine and right lateral position. If the fluid is present only in the supine position or in only the right lateral position, so if it's only in the right lateral, you can grade it as grade 1. If the fluid is present in both the supine and right lateral decubitors, then it probably falls under a high risk category, because the amount of content in the stomach is likely to be more than 100 ml. That is what the current studies show. If the fluid is found only in the right lateral decubitors, there's a 75% chance that the volume in the stomach is likely to be less than 100 ml. If it's found in both the positions, then probably there's a chance of having more than 100 ml in the stomach. The next comes, can we estimate the exact amount of contents in the stomach? Studies have been on for more than a decade or so. People have worked on various models. And one of the models which I like is in which you identify the stomach, freeze the image, identify the walls of the gastric antrum, most of the machines do have a hand tracing technique. You can hand trace it all around or put in an elliptical cursor and measure the cross-sectional surface area. This cross-sectional surface area has a linear correlation with the amount of content in the stomach, that is the gastric volume. At least 4 or 5 different equations or formulas are have been given. The most popular one, which I also feel that it's quite appropriate, is the one which has been recommended by Anna Hyperlas, etc., working at Toronto. This has got only one variable which is we have to measure, that is the cross-section area. The other ones are reasonably fixed for the age and of the patient. So, so what we have to do is you carefully identify the stomach, freeze the image, and identify the walls of the antrum, put a cursor around it, and measure the cross-sectional surface area. Now, in this diagram, you can see that the cross-sectional surface area is 16.62. You put that whatever value obtained into the formula, and you can get at the end of the equation, you can get what is the estimated volume in the stomach. If the volume is more than 1.5 ml per kg, you can say it probably falls under high risk, and they take steps accordingly. If the volume is less than 1.5 ml per kg, then you can safely say that the status of aspiration is low. Now, this is in general. When you want to do gastric ultrasound, you have to scan it in 2 positions, that is in supine and right lateral. Of late, people have been using the semi-recumbent as well. Do the scanning. If you find solids at any point of time, that means it is a high risk for aspiration. If it's empty in both the positions, you can get it as 0. If you find clear fluids, then find out if the fluid is only in the right lateral decubitus or in both supine and right lateral. If it's only in right lateral, the volume is likely to be less than 100 ml and low risk for aspiration. If it's more than 100 ml or position in both the positions, in supine and right lateral, then the risk of aspiration is slightly higher. You can go on to do the volume assessment if you want. If the volume is greater than 1.5 ml per kg, that means the risk for aspiration is high. Volume less than 1.5 ml is probably the risk of aspiration is low. How does it appear in a full-term pregnant woman? Now, in this images, you can see that if we go through systematically, we can identify most of these products in the structures in the image, starting with liver, the aorta, the superior mesenteric artery. The one on the right side is the uterus, which is pushing all the contents up. The stomach is compressed between the liver, the uterus, and the duodenum and pancreas behind. If carefully going through, we can see in probably part of the image, you can see that the fetus is coming. The respiratory movements are fairly fast. These are all the things which makes it slightly tricky, but it is possible to gain expertise to visualize the gastric antrum in the pregnant woman. There are at least 4 or 5 different equations which have been given, which people have worked on, and they have created models to estimate the contents in the stomach. One is identifying the quality of the contents, that is whether it's solids, liquids, or semi-solids. Semi-quantitative, to go on to see whether it is there in both supine and right lateral. And if you want to estimate, there are, as I told, there are 4 or 5 different equations to be given. People are also trying to work on one single measurement which can give us an idea whether the risk is high or not. There is still no consensus, but somewhere between 6 and 9.6 is probably what people are working on this. We are yet to get the final agreement on this. The other way of measuring the contents is measuring the diameters in 2 perpendicular planes, put it in the formula, and get the total volume or estimated volume. How to use this? Fortunately, people have worked on this and given how to use when we are doing this as a point of care tool. This they've labeled it as IAM protocol. Means when you want to do, you should have an indication, acquire the image, how to interpret it, and how to use them for medical decision making. The indication for performing a GUS are when you don't know whether the patient is NPO or not, when you want to take up for an emergency procedure. These are the conditions in which you can perform gastric ultrasound before starting your anesthesia so that it can help you make a decision. Acquiring the image, the preferred position is right lateral decubitus. You can do it in supine and semi-recumbent as well, but right lateral is the most appropriate position for detecting even the minimal amount of contents in the stomach. Interpretation, all we talked about was qualitative, semi-quantitative and quantitative. This helps us to go systematically. And how to use this? Again, knowing the stomach is full or half empty is one thing. How to use it? Basically, if you come to know that there is content in the stomach, you can decide whether you want to proceed or you want to postpone it or cancel it and take it for next day, and decide whether if you want to go ahead with GA, whether you want to take precautions like rapid sequence induction. All these precautions can be taken if you want to proceed with GA. Now, one of the articles which has been, it has been so popular, that gastric ultrasound, so many studies coming up. Last year, the end of the year, there was a publication, on the role of gastric ultrasound during pregnancy and postpartum period. A systematic review has performed. In this, they have looked at mainly 5 important questions about the role of gastric ultrasound in obstetrics. First is, using gastric ultrasound, can we determine the gastric contents? Can we quantify the volume of contents in the stomach? Can we differentiate between high and low volume states? Can we develop, and is there any sufficient evidence to say that we can say this is the cutoff threshold for the gastric cross-sectional area? And also, in patients who are laboring, etc., can we determine the rate of emptying? These are the 5 questions they have looked at while trying to do this systematic review. The answers are, yes, it is possible to do qualitative differentiation. When you perform the gastric ultrasound, you can clearly make a differentiation between solids, liquids, and semi-solids. Can we quantify the volume of contents in the stomach? Yes, there have been at least 4 models which have been developed. Most of them differ slightly, but all of them can give a relatively accurate estimate of what is there in the stomach. So, and can we differentiate between high volume states and low volume states? Yes, definitely. In that way, we can make whether the risk is low or the risk is high. If you're proceeding, what precautions you need to take, you can make a medical decision. Cutoff threshold, still there is no consensus. But somewhere between, when you're doing it in supine position or right lateral is the 2 things which we can look at. If in supine, people are coming up to a value of around 608 millimeters square as the threshold beyond which the risk of aspiration is high. In right lateral, if your cross-sectional surface area is more than 960, it probably is a risk for aspiration. Again, there is a difference in between various people working in this field, but still the consensus is yet to be out. And because of if you are able to perform this, you can carefully analyze what is happening with gastric emptying during early pregnancy, mid-pregnancy, late pregnancy, and in labor. The findings suggest that till 3rd trimester, there is no change in the rate of gastric emptying. But even in final trimester or during labor, the fluid transit in the stomach is not affected. Even though the emptying of solid content in the stomach is delayed during 3rd trimester, or probably during labor, so it can be delayed, but fluid transit is not affected. So as a result, the policy of being liberal about giving fluids during labor, etc., probably should be encouraged. Now, before I finish my talk, I want to give some very images which you can carry home, and when you start performing gastric ultrasound, it will be very useful to you. This is the appearance of the stomach when the stomach is flattened out, when it is empty and it's flattened out. It's a typical target shape appearance. When you find that there is a little bit of clear fluid with here, this is the clear starry sky appearance what you will get when you do this gastric ultrasound. The solids, as they stay in the stomach, they get digested partially, and they don't block the ultrasound waves. As a result, you will see a frosted glass appearance in the late phase of digestion when the solids have been eaten. This is how probably you would see in a 1-year-old child. Now you can see clearly the almost all the 5 layers in the gastric antral wall. This is one of the cases in which a patient was coming for a with a urosepsis for digestion. You clearly see the stomach is filled with both liquid and solids, and this is a characteristic appearance you will see. And this was a case in which where the stomach and the small bowels were dilated because of the fluid content, and this is slightly different from how you normally would see a stomach with the solids, etc. And I also want to show you a few pictures from sequential scanning in a volunteer, in which I asked him to come empty stomach. When he was fasted for more than 8 hours, you can clearly see the stomach seems to be empty. There is peristaltic movement. The 2 walls of the stomach are opposing each other. When you put him in right lateral position, you can clearly see a small increase in the volume. That is because of the residual gastric secretions. If only a very, very small increase, you probably are seeing only during the peristaltic movement. This is normal to see. Now, after that, I gave him our carbohydrate drink or high energy drink. You can clearly see the stomach is getting dilated. The clear hypoechogenicity is starting to appear in the middle of the gastric antrum. When you turned him right lateral, you can clearly see that the antrum is getting dilated with peristaltic movements. More and more fluid is getting pushed into the antrum. As a result, you can see a little bit of air and the stomach getting dilated. After this, you can clearly see that by around 2-3 minutes of lying right lateral, it's clearly the stomach is quite dilated. You can use this volume estimation method to estimate to see how whether it correlates with what we have given. After this, again 5 minutes was very similar, and after this I gave him a masala dosa as a drink. This was immediately after the meal we had. You can see clearly mixture of solid and liquid contents. This was in the supine position. When I turned him right lateral, you can see the stomach gets hugely dilated. The mixed echogenicity and with peristalsis, there's a bit of movement here and there. All this suggests that the stomach is full in this case. And before we find if you want to measure the cross-sectional area, you can see you can freeze the image, use your hand tool to draw around the gastric antrum and measure the cross-sectional area, put it into the formula and obtain what is the estimate of the content. Finally, this is what you would get to see in a pregnant woman. You can clearly see the liver, the aorta, the superior mesenteric artery, the bottom of the images, uterus pushing the contents up, this stomach with its contents, the gastric antrum. Clearly see there is some amount of contents in there. This was a lady who was coming for emergency C-section. Clearly you can see the respiratory movements are quite rapid. The stomach is being pushed up by the fetus there, and you probably are seeing some placenta there at the upper end of the uterus there. In essence, what I want, the take-home messages from this talk is that yes, gastric ultrasound is a powerful point of care tool. It's focused and goal-directed. It can determine the gastric contents and assess when we can use it to assess the aspiration risk. It can help us guide the anesthetic and the airway management. It's easy to learn and can be used in obstetric patients, and it's fairly accurate and reliable. Thank you very much. Wish you a good luck. Thank you.
Hello, everybody. My name is Dr. Chikermane, and I am a consultant obstetric and pediatric anaesthetist from University Hospitals Birmingham NHS Trust. Thank you for this opportunity to talk to you across the continent via this video link. I'm going to talk about non-cardiac medical comorbidities which present to us in pregnant women, and how we can simplify these challenges. And there is no disclaimer and no conflict of interest. I come from Birmingham, which is right in the middle of United Kingdom, and this is our hospital, the Heartlands Hospital, which is a part of the University Hospitals NHS Trust. This is the Princess of Wales Women's Unit, and we see a wide variety of weird and wonderful morbidities which present to us on a labour ward, keeping us on our toes. I would like to start by saying that anaesthetic assessment, as we all know, plays a very important role in this. Or between the pregnancies. We know that these women are associated with higher comorbidities like cardiovascular disease, diabetes, sleep apnea, respiratory compromise, which makes them prone to various complications. They also have higher peripartum complications like preeclampsia, thromboembolism, gestational diabetes, and also dysfunctional labor, higher chance of instrumental deliveries, and therefore anesthetic interventions. They might have VBACs if they've had previous pregnancy or a failed induction, or also and higher incidence of third or fourth degree tears, which would present to us in theatre. So what are our goals for these women? I think the most important goal is to get a good outcome for the lady. And so therefore we need to consider difficult airway management, aspiration prophylaxis, and maintenance of stable hemodynamics if they come to theatre, because sometimes the paniculus can cause hypotension. Also, equipment issues need to be taken into consideration, and also how you're going to position these women. During labor, it is important if early epidurals are possible, which might be possible but not always feasible. So whenever it's a good idea to pre-assess these women, or when they are in induction, to give them advice about labor, give them the leaflets so that they are prepared for it. And when I put epidurals in these women, I railroad the catheters so that they have less chance of coming out, getting dislodged, because these women can sometimes be very sweaty, and which can cause the epidural catheter to come out. So therefore, it's a good idea to sometimes railroad these catheters. And then obviously, if they have to come to theatre, the choice is whether she can have a general anesthetic or a regional. Regional is always the priority, because it reduces all the issues and challenges which a general anesthetic can have. So therefore, we need to weigh the risks and benefit depending upon the situation and the women's needs. If they have to have general anesthetic, Then we have a lot of airway aids like the CMAX, which we've used quite a lot as a part of our intubation trolleys during COVID times. And most of us are quite good at using video laryngoscopy, using Oxford Help pillows. Even if the regional technique is successful, I always keep the Oxford pillow ready and ready on the patient. So just in case we have to give a general anesthesia, a general anesthetic. Case 2 is a lady who presented at 36 weeks of gestation, who was gravida 1 with an IOL for thrombocytopenia. It's with serial low platelets from 30, 25, and 15. And her clotting was normal, but she had impaired renal function. So thrombocytopenia can present in various forms. It can be gestational, which are gradually reducing numbers, but usually is mild to moderate. And if the numbers are high enough for a regional technique, then that should be safe. It can also present as idiopathic thrombocytopenic purpura or thrombotic thrombocytopenic purpura. And those can be a bit challenging because if the platelets are really low during early pregnancy in ITP, or less than 50 during late pregnancy, then we might have to give them IVIG globulins or a platelet transfusion. A plasma exchange might also be advisable in thrombotic thrombocytopenic purpura. But whatever the cause, we need to be safe and be wary that these problems, the thrombocytopenia, can be presented in the baby as well, and also try and use safe delivery methods like reduce traumatic incidence of traumatic deliveries, and also maybe measuring platelets in the baby in the neonatal period, as they might present with fetal thrombocytopenia. What is a safe platelet count for these? I think 70 is the new 100. And I think many of you might agree with me because we've just had the recent OAA meeting where it was discussed. But as long as the clotting profile is fine, I think platelet counts of 70 is good enough. I recently anesthetized a woman who had non-Hodgkin's lymphoma and her platelets were fairly low, although she was in remission. So we did give her a regional anesthetic, but the problem was that she bled afterwards, and that's a story for another day. So the other hematological challenges which women might present to us would be reduced oxygen carrying capacity, like sickle cell disease and anemias. We need to be careful as to good oxygenation, ventilation, preventing hypothermia, and also avoiding hyperventilation in these cases. Risk of clotting is very predominant in pregnant women because of their increased thrombotic state, and therefore and it carries significant morbidity and mortality. They may have underlying conditions like thrombophilia and factor V Leiden deficiency, so they might be on thromboprophylaxis for that, or women with big BMIs and might need thromboprophylaxis. So those are really important challenges which we need to think about. So routine thromboprophylaxis in these patients can result in significant reduction in morbidity and mortality. We have guidelines on our unit, and I'm sure there are available across different units as well. We normally advise we normally give enoxaparin 4 hours after a regional technique, or avoid a regional technique if the women have been on prophylaxis for any of the thrombotic problems. So 12 hours if they are on a anticoagulant dose, or 24 hours if they're on a therapeutic dose of enoxaparin. There are various oral anticoagulants which are available, and which are not been approved for pregnant women, but one needs to be aware of their pharmacokinetics and dynamics so as to decide what anesthetic techniques are within the limits of the available guidelines. So therefore, it's important to have detailed plans for the management of labor. What is the risk and benefit for regional anesthesia and general anesthesia? If regional anesthesia is contraindicated, the woman should be told what her options are available and whether we could use patient-controlled analgesia for her. Another case, which was a lady with cystic fibrosis, 36 weeks. She DNA'd previous antenatal appointments, felt unwell, so presented to us with nocturnal cough and green sputum. So these can present in various forms and present different forms of respiratory challenges. And I think the most important thing in these is to optimize the underlying disease and monitoring infection, controlling it. For example, in this lady, she had inhaled tobramycin and serial respiratory function monitoring to see how her disease was progressing, whether it was getting worse, optimized treatment, whether it is in the form of oxygen, non-invasive ventilation, CPAP, and also protection against flu. Regional techniques are beneficial in these cases because they reduce the workload of breathing, they help the oxygenation, and also reduce the effects of a general anesthetic, which might obstruct the respiratory function. All these women need to be monitored in a high dependency unit setup. So therefore, good communication with obstetrics, the intensivists, and the anesthetists is of vital importance to get good outcomes for these ladies. Another interesting case which we came across was this gravida 3 para 4 with previous normal deliveries, 36 weeks of gestation with this euthyroid goiter. She presented to us with inspiratory stridor, difficulty lying supine, although she could breathe well in left tilt and in lithotomy, which was good, and also manage valsalvas. On CT scan, we found tracheal compression, and so therefore, obviously, as we decided that it all has to be done as a multidisciplinary team effort, we contacted the ENT team along with the obstetricians, and a plan was made. So obviously, we decided that regional would be safer, and if she had to have a general anesthetic, the ENT guys suggested that she shouldn't be a problem during intubation, but she might have an airway collapse during extubation. So it was decided that if she was to have a general anesthetic, we would take her to ITU to extubate her there with the presence of ENT surgeons who might have to do an emergency thyroidectomy for her. Also, she was advised to have steroids during labor to reduce airway edema. If she needed theatre, she could. We planned that the surgeons, the obstetricians, were happy to do lithotomy with head up and reverse Trendelenburg position as well. So positioning was thought about. The ENT surgeons also suggested that we use heliox with the face mask to improve laminar flow and reduce the turbulence to reduce the stridor. But the problem with heliox is that it's 21% oxygen, so therefore makes it a hypoxic mixture. So we had to think of other ways of giving her oxygen. And obviously post-delivery ENT for a thyroidectomy. Luckily for us, she delivered normally. So that's the good way to go. And hopefully she's had her thyroidectomy by now. The next case, which presented to us in one of our specialist clinics, was a gravida 3 para 2 with altered sensation and burning to the left arm and then to the right arm. She had no visual disturbances and had stress-related exacerbations. She had difficulty passing urine, and the MRI showed demyelination. So this lady, as you all must have guessed, is a lady who presented with multiple sclerosis. And we commonly see these women. Usually they are well, and if they don't have any neurological signs or symptoms, like the reflexes were normal in this lady, and we thought that regional technique should be fine, and giving her all the data with what the complications of epidural and spinal could be with so those were given to her, but with the proviso that if she has exacerbations during pregnancy or labor, then we would not be able to give her a regional technique, and a general anesthesia would be the way to go. So neurologically, a lot of women present to us with different challenges, which could vary from seizures, epilepsy, or myasthenia gravis, multiple sclerosis, or central core demyelinating diseases. It's important that we take a good account of these on pregnancy and labor as to how they affect how the disease gets affected or the pregnancy gets affected. We need to identify the residual issues and how they will be managed. And good multidisciplinary teamwork with neurologists, obstetricians is of prime importance. So regional anesthesia most of the times is fine, apart from strong excluding contraindications, like if there's a spina bifida or an Arnold-Chiari malformation, which is extending quite further down with neurological symptoms, or tethered spinal cord. If a woman presents with myasthenia gravis, then we need to see that she's got good anticholinesterase medications on board, controlled disease, and regional anesthesia would be preferable. Multiple sclerosis, as we've just discussed. If the seizure control is really important, if women present with epilepsy, because not only the disease but the drugs also affect fetal well-being and also their obstetric outcome. Whatever type of anesthesia we give, whether it's regional or general, neuroprotection is of prime importance, and we need to be sure that we control the carbon dioxide oxygenation and reduce issues which can raise intracranial pressure. Psychiatric disorders have been highlighted in many of the maternal morbidity and mortality reports and do pose a significant issue. So it is very important that anesthetists work in conjunction with the psychiatrists, because many of the psychiatric drugs can have adverse effects on our anesthetic agents. And it is very important for maternal well-being as to how they're going to be cared before, after, and during the pregnancy. Moving on to connective tissue disorders, there are a wide variety of these which present in weird and wonderful forms and affect pregnancy and the baby in different ways. So we need to be aware of how they can present to us and how we can individualize treatment for the women based on the diagnosis. So they can have airway issues like fixed flexion deformities, affection of the cricoarytenoid cartilage in rheumatoid arthritis, or ankylosing spondylitis. So therefore, fiber optic intubation, if skills should be available or if they can be done during elective hours, that would be great. But that never can be a possibility. So the proper skill mix should be available when these women present to us on the unit. They also have multiple systemic effects, like they are high aspiration risk. They may have renal cardiovascular involvement or respiratory involvement, like in sarcoidosis, scleroderma, venous access and positioning may be a problem. So they are all multidisciplinary effects of these diseases. And therefore, the treatment for these women has to be individualized, tailor-made to what their presenting comorbidities are and how we're going to reduce morbidity so that they have the best experience of labor. Moving on to renal diseases, I think the most important points which we need to remember are that urinary tract infections are very common. We need to treat asymptomatic bacteriuria because they can cause preterm labors and IUGRs. So it's very important to treat them. Acute tubular necrosis is common among developing countries, and chronic renal disease has an increased risk of IUGR and preeclampsia. Renal obstruction and failures can present from a gravid uterus or stones, and therefore, if nephrostomies are needed, they might have to be done during pregnancy to reduce the morbidity. So therefore, the management involves good fluid management and control, because we need to be vigilant, as it can affect neonatal and obstetric outcome. These women might present with great fluid instability, because they might have hyperemesis or diarrhea. So fluid management is of great importance. Regional anesthesia is considered safe as long as clotting abnormalities are not present. If thinking of GA, a TIVA approach might be more useful because inhaled anesthetics can cause renal toxicity. A remifentanil infusion is good because it's short-acting opioids and can also be used postpartum and during pregnancy as a PCA. So that helps as well. Muscle relaxants, atracurium is good because it doesn't undergo renal or liver metabolism. Succinylmethonium should be avoided if we're thinking of hyperkalemia because that might cause problems. I cannot finish my talk without talking about COVID-19. Women with underlying health conditions like diabetes, respiratory problems like asthma, obesity, are all prone to are more prone to having COVID-19. Ages over 35 and deprived socioeconomic conditions. Third trimester pregnancy and Black and Asian minority groups we have seen in the United Kingdom are more prone with the COVID problems. The complications of these women are twice likely that their babies will be born early, more likely to develop preeclampsia, which we've seen a lot on our unit, and also the way they present. They're fit, well, young women, and then suddenly develop respiratory problems and who need intubation or other types of non-invasive ventilation. Vertical transmission is much less in these cases. So the UK obstetric surveillance system, which is monitoring data from March 2020 to the end of September 21, has come up with some preliminary data which say that women are not more likely to get COVID as compared to healthy adults, but are more likely to have pregnancy-related complications, and therefore there are higher admissions to intensive care unit as compared to non-pregnant women, and also we don't know whether long COVID how long COVID would present in these pregnant women. A vaccine is recommended by the JCVI, and Moderna or Pfizer vaccine is the one which pregnant women should be given. So therefore, but it is very important that these women are looked after well with multidisciplinary team approach, and as much as possible that non-invasive ventilation methods are used so that they can so that we avoid the complications of intubation. I would like to conclude my talk that a thorough pre-op evaluation, perioperative evaluation during the antenatal period and the perinatal period is of utmost importance to reduce morbidity and mortality in any women presenting to the labor ward. The choice of anesthetic and multidisciplinary team involvement, good communication skills, and also good documentation so that we know what has happened so far. So we have Bajonet systems on our unit, where every team notes down what they've seen and evaluated of a particular patient so that there is continuity of care and nothing gets missed, which helps with giving the best care that the women need. Thank you very much. I hope you enjoyed my talk and will be able to answer some questions.